Welcome to Nephrology Today, the podcast that brings you the latest insights and discussions in the world of kidney care. I'm Michelle, and today we're thrilled to welcome Dr. Farida Magali, a nephrologist with our NANU South Chicago location. Welcome, Dr. Magali. So happy to have you.
Hi, thank you so much for having me. I appreciate it, and I'm excited to be here.
So today we're going to be discussing women in nephrology, which I'm really excited about. So why don't you start by giving us a brief background about where you're from and how you got started in nephrology?
Sure. So I grew up in Dayton, Ohio. So I'm from the Midwest. And then I ended up going to college at University of Michigan, and then made my way to medical school in Washington, D.C. at GW. And then I landed at Rush for my residency and fellowship for nephrology. My father is a physician, and I have other physician family members. So that was always an inspiration for me to go into medicine. And then naturally in school, I fell more into the math sciences were my strengths. And so going to medical school, applying to medical school was always in the back of my head. I guess I fell into it. And my family was always super supportive of whatever I wanted to do. So that kind of led me to a career in medicine. I guess to say what led me to nephrology, it was honestly, I fell into it also. I obviously loved internal medicine and was interested in several different specialties. I knew I wanted to subspecialize. And then I did a nephrology rotation during, I think it was my second year of internal medicine residency at Rush. And I just really loved it. It was a lot of problem solving, it was math, it was really just not memorization, which I absolutely hate, which almost I didn't make it through med school because I hated memorization. So it was a lot of problem solving, and it was also diverse patient population, inpatient, outpatient. So it had everything that I wanted in a career.
That's great. So, how would you say nephrology has evolved since you started your career?
So I think in general, I think once when you're in academics, it's so different than private practice. But I finished fellowship in 2017. And I think one of the big things that's occurred, I guess, in nephrology in the last 10 years is the introduction of new drugs for our patients. For the longest times, at least for general CKD, obviously not speaking about immunosuppressants for our GN patients, but ACEs and ARBs were always the medication fallback as what to use. But now we're really getting lucky in that we have SGLT2s available. We have new nonsteroidal MRAs, GLP-1s like Mounjaro and Ozempic. Those drugs now, there's more and more data to suggest that not only do those drugs benefit specifically patients with diabetes, but they're actually benefiting our patients with chronic kidney disease. So really that's a game changer. And I always impress upon my patients like how lucky we are to have those drugs. And I always say that nephrology might not necessarily be a sexy specialty, but we're a super, super important specialty that I think, unfortunately, the kidneys tend to be forgotten sometimes. And we are a very important piece of the puzzle when it comes to patients and their healthcare. The other things, in addition to therapy, so obviously I'm not going to go into it. There's more and more therapies for glomerular nephritides, especially IgA, FSGS. We're having more immunosuppressants available for us. And then I think nephrology as a whole is the value-based care space. Obviously, nephrological care is very expensive in the United States. And so how can we provide quality care to our patients, but also at improved cost? So that's been something very big in the nephrology space in the last few years as well, which NANI has participated in the KCE and with value-based care.
Yeah, lots of changes over the span of a decade, I would even say.
Yes.
Can you tell me what advice you would give to young women doctors considering a career in nephrology?
Sure. I think in general, anybody considering a career in medicine, I think obviously it's a big commitment. So I think if it's your passion, definitely go for it. But I think in general, whether it be medicine or going into nephrology, I think you really have to be in love with what you're doing. Can you see yourself happy long term? Can you see yourself doing this for the bigger part of your life? And is that a commitment that you want to make? I know that every day when I go to work, I enjoy what I'm doing. I'm happy with what I'm doing. I feel like I'm making a bit of a difference every day with different patients or the healthcare system. So I genuinely do enjoy what I do, and I would just communicate to those that are following to really enjoy what you do. I think considering academics versus private practice, those are all things that come later on because those are obviously different spaces as well. And then most importantly, I think that people considering a career in nephrology just never compromise what you want and what you like. If you're interested in a career in nephrology, but people might say certain things, and like I said, it's not one of those quote unquote sexy specialties, like it's okay. You can make your career what you want it to be. You can be in academics, you can be in private practice, you can be in pharma, all these different things. And there's so many different avenues to make a difference in nephrology.
Would you say women face any unique challenges specific to nephrology?
Sure. I think in general, nephrology has been well documented as a male dominated field. In 2019, there was data that said that only 30% of practicing nephrologists in the United States were women, and then 36% of trainees were women. Again, that was data from a few years ago, so hopefully that has improved. But I think that because there's decreased amounts of women in the field, that's reflective in mentorship and leadership as well too.
Doctor, would you say that when it comes to disparities in leadership opportunities for women in nephrology, that they exist? And what changes would you like to see?
Yeah, I think just like in any field, corporate America or in healthcare, sure, there is room for improvement and there are disparities in the amount of women that are in leadership positions. We know that in the United States, only 6% of departmental nephrology chairs are women and about 9% of division chiefs are women. So obviously, there's room for improvement. Like I said, there is a decreased amount of women in the field. Hopefully, in the future, that we can increase that because we do know that is an increase in applicants, female applicants and matriculants in medical school. And then I think that over time, just like things evolve in any field, I think that women will start joining male dominated fields, particularly nephrology. And what we do know from the data is that women in academic faculty positions have been increasing over the years. And currently it's at 45% nationally. We don't have a lot of data in the private practice sector, but things that are happening in academics can hopefully be trickling down to the private practice sector as well.
Yes, those numbers are promising. And hopefully, as young ladies listen to our podcast on Spotify or across other channels, they will be maybe compelled to begin their career in nephrology.
Yeah, being inspired to grow the field of nephrology, whether if it's women or minorities, really, I think that our field is going to start looking more like our world in general. We are becoming more of a diverse environment, and hopefully our field will look that way. But I think the most important thing is that we just really need to be mindful of those things and making sure that women have an equal space in the field of medicine and that they are able to have the same opportunities as their male counterparts. And how that will lead into, will there be more leadership opportunities, mentorship opportunities? Will women be supported in addition to leadership opportunities being a challenge, but also women or get pregnant? And will institutions support women for childcare and parental leave and all those things? I think that we're getting better at that. Nanny specifically actually has a maternity leave in place, which I think will really support younger physicians when they're planning to have families and planning their pregnancies. I think, like anything, everything's a work in progress, but I think that really being mindful of how the world is changing and making sure that we incorporate those things into how we practice is really going to be beneficial for not only our physicians, but creating a better work-life balance for those physicians in order to provide better patient care.
Yeah. And you bring up a good point. Work life balance is so important, which makes joining a practice like Nanny so attractive to young doctors. With all your experience with being a nephrologist, you're still considered a younger doctor. What would be your goals for the future?
Sure. I think coming right out of fellowship, going into private practice, there's such a steep learning curve. And I feel like I've finally gotten to a place where I feel comfortable practicing medicine and branching out into more of hospital committees and committees within the actual organization of nanny. So I think my goals for the future would be outside of obviously my clinical responsibilities and taking care of my patients, being more involved with committees for the hospital, which I'm actually on a few currently, and then also being involved with nanny as a whole, continuing to be involved with certain committees, but potentially if there are opportunities to be on leadership committees, that would be wonderful. I would be very interested in participating with those. Another thing that I think is so important for younger physicians is mentorship. I think that is something that was so vital in my growth as a nephrologist from being a fellow to now. I think it's so important to have people who are in your corner, who are cheering you on when you go through successes or failures, that they're the ones that you can have a sounding board for. So I think, yes, being involved with more mentorship opportunities. And then finally, if the opportunity presents itself, I have always had a passion for teaching and being involved with trainees. If there's opportunities to educate current fellows on private practice and how that works, I think that would be really important to their educational journey.
Yeah, no, that's perfect. I love it. We're going to switch gears now, doctor, and talk about women who have chronic kidney disease. And we're going to talk about some more of the specific risk factors for kidney disease that disproportionately affect women.
Okay. Sure. So I think generally speaking, 1 in 7 adults in the United States, about 14% of the population, have CKD. 9 out of 10 adults with CKD do not even know they have it. And then 1 out of 3 people with severe chronic kidney disease don't even know that they have it. So again, unfortunately, there's a huge disparity in general in patients knowing if they have CKD or not. But I think when it comes to women, there's a slightly higher prevalence for women having CKD, about 14% versus 12% in men. There was a higher prevalence, like I said, in women to have CKD, but specifically for men, more men are actually on dialysis, which is an interesting thing to know. And then I think also globally speaking, more women are likely to be kidney donors, but men are more likely to be the recipients. So I think when thinking about why women have a higher prevalence of CKD, but more men are on dialysis, more men are getting transplants, those are statistics globally. So it's interesting just to ask ourselves, is this like a sociocultural thing? Is this a genetic thing? Unfortunately, we don't really have a lot of answers to those. I think historically speaking, more women go to the doctor than men. So, maybe CKD is just being picked up in more women. And that's why 14% of women actually have CKD over the 12% of men.
Wow, that's interesting. I guess I didn't even think about that, but yeah, that would make sense. That's why it's being picked up in women. How do hormonal changes throughout a woman's life, like pregnancy and menopause, impact kidney function?
Sure. So I think risk factors, going back to the risk factor thing for women specifically, obviously women get pregnant in their life. That increases their risk for developing preeclampsia, for pregnancy induced hypertension, gestational diabetes. And then women's anatomy are different than men. They are more predisposed to developing UTIs. But when thinking about women, it's important to consider the woman's lifespan. Obviously, women in childbearing age are potentially going to get pregnant. So I think when you see a patient in clinic, it's super important to always be thinking in the back of your mind, okay, is this a patient of childbearing age? Is this a perimenopausal woman, a postmenopausal woman? And then how do you approach, specifically in my clinic, when I see a patient who is of childbearing age, I'm always thinking about preconception care. Because if we are not giving our patients the tools to plan and be aware of how their condition can affect their future, then we're not really doing a great job even if we're managing their hypertension or their proteinuria and things like that.
When thinking of the risks of pregnancy for women with kidney disease, what are they? And let's include those that are on the dialysis.
Sure. So I like to think about CKD and dialysis kind of separately, even though they're related. When I'm seeing a patient in clinic with CKD, like I said, I like to think about preconception care. So, number one thing we need to be asking our patients about is contraception. What type of contraception are they taking? Are they planning to get pregnant? What are the discussions around this? It's sometimes we're so focused on hypertension and all these other things, but this is just as important. Generally speaking, for patients with chronic kidney disease, if you're looking for contraception, the kind of most preferred option is a long acting contraceptive like a copper IUD or Mirena IUD. Short acting contraception is okay, but generally speaking, progesterone only pills are preferred over estrogen progesterone combinations because we do know that estrogen can potentially increase your thromboembolic risk. And we know that CKD patients with proteinuria, specifically nephrotic patients, are more at risk of developing those blood clots. If a patient is planning pregnancy, you should be looking at medications. So ACEs and ARBs should be discontinued if patients are planning pregnancy. With SGLT2s, the data in pregnancy are lacking. Animal studies show that it could potentially affect kidney development in the fetus. And then also, if a patient is on immunosuppressives, if they have an autoimmune disease such as lupus, or if they're post transplant, then you need to be talking to them about those medications and making alterations if needed. Diuretics can be used in pregnancy and obviously certain blood pressure medications. Once the patient does get pregnant, they should be seeking out an MFM doctor in addition to seeing the nephrologist. And then what things can those patients be doing to decrease the risks? Because we do know that patients with chronic kidney disease, especially stages 3 through 5, they do have risk of worsening renal failure during pregnancy and a higher risk of requiring a replacement therapy postpartum. We know that CKD is associated with reduced fertility and it can increase your risks of preeclampsia, preterm delivery, fetal growth restriction, low birth rates. So again, super, super important for those patients to be following with a nephrologist and with an MFM.
Yeah, no, really great information. Doctor, can a transplant patient get pregnant?
Sure, yes. Transplant patients can definitely get pregnant. Live birth rates for transplant patients were almost 73%. And the first birth that was documented in a post transplant patient was in 1958. So this isn't new. Obviously, I think when we hear, oh, transplant patient wants to get pregnant, everybody is scared. They're worried about what will happen. But yes, definitely it happens and it should happen. Those patients should have the opportunity to be pregnant, grow their families if that's what they want to do. I think something super important to remember is that after you get a transplant, your hormones come back into play that might not necessarily have been there previously. We know that patients with CKD and patients on dialysis, they have very erratic menses a lot of the times due to changes in their hormone levels. And so post transplant, those hormones can return back to their normal function as early as 6 weeks. And it's been well documented that your libido and sexual function can improve as well post transplant. If you are a young patient and considering getting pregnant. And even if you're not considering getting pregnant, it's super important also to have those contraceptive plans with your transplant physician or your nephrologist. We know that certain immunosuppressives like mycophenolate that can decrease the estrogen concentrations and oral contraceptives. So really being mindful that you could get pregnant essentially almost 6 weeks post transplant, which is not preferred. I think generally speaking, again, I'm not a transplant nephrologist, but generally speaking, they want people probably to plan getting pregnant like after a year post transplant, just to avoid any complications. If they need to change medications, they want to make sure that the graft function is good. And then a really important thing is to consider CMV. If you had CMV viremia during your post-transplant course, how would that affect the baby. And obviously, CMV is a torch infection. So you want to avoid being pregnant up to 6 to 12 months if you were CMV positive.
Wow, that is extremely helpful, especially for young women who have chronic kidney disease and are going through all the stage in their life. So really great information. Is there anything else you'd like to add, either from a woman considering a career in nephrology or a woman dealing with chronic kidney disease?
Yeah, I think just to conclude, I think it's always important, regardless of what your sex, your age, your race, do what you want, do what inspires you, do something that you're going to be happy with and that you see yourself doing for a while, because a commitment going into medicine in general is a big commitment. So you want to make sure that you're happy with your decision. And then when it comes to patients, female patients living with CKD, I think it's important that they can do the same things that patients without CKD can do. They can get pregnant. They can have healthy babies. They can get transplants. They can leave similar. And even if you are on dialysis, you can still get pregnant. Certainly, there's different considerations where you're going to be probably doing daily dialysis and increased monitoring. But I think it's really important to keep in mind that these things are possible and that with increased guidance and oversight from your physician, that really anything is possible. I think keeping a positive outlook on that is vital to guiding your patients to whatever journey that they want to pursue.
Oh, absolutely. Doctor, thank you so much for joining us today and sharing so much insightful information. If you would like to learn more about NANI or get in touch with us, please visit nephdocs.com. And please listen to this podcast on Spotify or wherever you get your podcasts. So again, Dr. Magali, thank you so much for being with us today. We
Thank
hope
you
you'll
so
join us
much.
again.
Thank you so much. Appreciate it. Take care.
Bye-bye.